Good evening, ladies and gentlemen. You are welcome to another edition of the program Through My Eyes Town Hall, where we converge to share thoughts and ideas on social issues affecting us around the world. Now, following the COVID-19 pandemic that ravaged the whole world, different countries and regions came up with responses tailored to suit their situation. This highlighted the lapses in healthcare provision, not just unique to sub-Saharan Africa. Today, we are going to discuss the challenges and opportunities of evolving healthcare in sub-Saharan Africa. Now, joining us on that, we have Dr. Tolu Olufunlayo, a public health medicine specialist. She is a senior lecturer at the College of Medicine, University of Lagos, and a consultant at the Lagos University Teaching Hospital. Dr. Tolu Olufunlayo has published several medical journals and is a member of the Association of Public Health Physicians of Nigeria. She holds a Bachelor of Medicine and Bachelor of Surgery from the University of Lagos and a Master of Public Health from Tulane University, New Orleans. Also with us is Dr. Debisi Olunloyo. She's a medical doctor by profession. She trained in the College of Medicine, University of Ibadan. And when she graduated, she moved to the UK to specialize in family medicine, that's general practice. She has over 2 decades of experience as a medical doctor and has worked as a general practitioner for the last 13 years. She's also a clinical director of the Etham Health Primary Care Network in Greenwich and a clinical project lead for Greenwich as part of South East London Clinical Commissioning Group. With this, let's begin the program. Over to you, Akin.
Good evening, doctors. Thank you for joining us this evening. It is such an honor and such a pleasure to have you both with us this evening. You're welcome.
Thank you. Good evening.
Thank you and good evening.
Excellent. Now, just before we went live, I was thinking about something. When I was growing up, my dad was a medical doctor as well, and he was a consultant pediatrician. And there was something we always had at home every time. And I thought that today, with 2 doctors in the house, I'm going to put this question to you. And this is the choice of words. We just want someone to take a blood, phlebotomy, all kinds of words. There is a cut, they say laceration. Where did all those kind of words come from? Dr. Olufunlayo, let me start with you. Where did they come from?
Most of them are, good evening once again, everyone. Thank you for having me on this program. Most of those words derive from the Latin words from which ancient medicine was first practiced. So, in fact, in my father's days, my father was also a medical doctor. They learned Latin in school as part of their medical curriculum to enable them understand better what they were learning. So a lot of those things have their roots in the ancient languages, but most specifically from Latin.
Well, Dr. Olunloyo,
makes it
Go ahead.
No, I was saying it makes it sound all big and everything, doesn't it?
It does. Dr. Olunloyo, let me come to you. When you're treating patients and you use some of these words, do they hear those words and feel, what is this? Doctor, please break it down in English.
Hi, good evening. Thank you for having me on this platform. I think that's part of the skill of being a doctor, is being able to communicate effectively with your patient. So even though there are these big Latin words, which we understand, you have a duty to speak to your patient in normal language, in a normal way that they will understand, whatever language it is. So actually, that's one of the gifts or skills of a very good doctor, is being able to communicate effectively and not use medical jargon. We're actually tested on things like that, on communicating with patients during our medical school.
Wow. All right, let's get into the crux of the conversation this evening, and that's for us to start to look at um, the challenges and the opportunities around healthcare provision in sub-Saharan Africa. Now it's key for us because, and one of the reasons I'm glad we have both of you on today is that we can also see different perspectives on the point here. So let me start with this point because our researchers were looking at the topics at the start, and one thing struck me, and maybe Dr. Olufunlayo, let me start with you on this point. Deloitte released a report, and they said the top 10 global issues are linked to behaviors that people could have adjusted, lifestyle behaviors that they could adjust. How true is that?
Well, that's very true. They're referring to modifiable risk factors. We're talking about things like, lifestyle, whether sedentary or otherwise, weight, smoking, alcohol, things like that. But I think we all know that human behavior is very difficult to modify. And there are a lot of programs, on behavior change and communication, and we have so many different terms for that. But the human being is very difficult to regulate. So, despite warnings, despite a lot of information that is out there to let people know that these things might be inimical to their health, there's still that interplay of the person's will that is involved. And of course, there are also genetic issues and environmental issues that interplay with all of these risk factors and end up producing disease. So one of the targets of public health really is to communicate with people to let them know what these risk factors that they can actually change are, so that they would then want to be motivated to make those changes and thereby improve their health. So
Dr.
that's really what it is.
Yeah, Dr. Olunloyo, in the UK, what do you see? Does the report fit what you see in the UK as well?
So I agree completely with Dr. Olufunlayo. Yes, there are modifiable risk factors. There are things that we can correct, we can deal with, and obviously there are things genetic as well that can predict diseases or a person developing diseases. So that's completely correct.
Wow. All right, let's go to COVID-19 and start with that. And Dr. Olunloyo, I'll start with you. One of the issues that we had with the pandemic is that it seemed to catch everyone unawares, even in the developed countries. Now, some people have said, well, it's an unusual scenario. It's one of those things that happens, once in a million years. So my question to you, Dr. Olunloyo, what was the level of preparedness in the United Kingdom, and what are your views on that?
Okay, so starting with COVID pandemic, I mean, to be fair, I would say it caught everyone unawares all over the world. I think that it also revealed the cracks in the various health systems everywhere. However, I would say that in places like the UK, I will talk about the UK now, we have systems in place that helped things to work out better, I would say. So obviously we have the NHS, but even with that, we know that the NHS cannot deal with every single thing, and we saw the cracks as people were falling ill. But then we've got primary care, which is like the bedrock of our NHS, our gateway into secondary care, as it were, to the hospitals. And so what we had was, we saw the system was failing and no one could catch up. But what we had in place, we had primary care in place, we had GPs, nurses, healthcare practitioners in primary care in place, and then we had secondary care. So we could quickly start working systems out to make things better. So for instance, like when all general practitioner GP surgeries closed their doors, they were still working by triaging patients, speaking to patients on the phone, helping to deal with those that could stay at home, those that still had other problems and didn't need to go into hospital. And then those that needed to go into hospital, to help them to go into hospital. And that was something that helped. With the COVID pandemic as well, you can see that with the vaccine rollout, it has been a real huge success in the United Kingdom, because what NHS England did was they came back to the grassroots, to primary care, and they got it rolled out that way. So we could call patients, because most people are registered with a GP. So we were able to call patients in according to the cohort and get them vaccinated. So what I'll say is those systems helped. We had them in place already and they helped. But regardless of that, the pandemic caught every single country unawares. I don't think there's any country that will say they were prepared and they dealt with it perfectly without revealing the cracks.
Dr. Olufunlayo, what was the experience on your side?
Okay, thank you. Talking about the response to COVID-19 in Nigeria, well, like Dr. Olunloyo has said, there was no country that wasn't caught unawares. But I must say that the previous epidemics that we've had to face did give us some measure of understanding of how to respond to epidemics and pandemics. However, the scope and magnitude of this particular outbreak was, beyond what we've witnessed in a very, very long time. So we found that we were able to quickly step up to the demands of dealing with a pandemic of this nature. Of course, thankfully, there was a lot of private sector and international support, for example, with the COVAX and vaccines that we're currently getting. The health workers had been trained in, infectious disease response and, of course, in infection preparedness and control, which are the necessary skills. So we were quickly retrained. However, the main challenges came with the hospitalization, because intensive care services that are needed, in a situation such as this, do not abound in our own health system. And that's one of the areas of great weakness in a health system such as that which we have in Nigeria. So that infrastructure wasn't there. But again, with the private sector and some international donors, we were able to mobilize quickly and get some things on the ground. Same for testing. But you see, the wonderful thing about this was that the projections, all the modelings that were done at the beginning of this pandemic in terms of the numbers and the severity we're going to see in Nigeria haven't really come to play. And for that reason, it's like we've just been able to manage, and keep this pandemic from overwhelming the health workforce in Nigeria. So I think it's a fortunate thing that this has happened, but it has definitely revealed the extreme weakness of the health system of a country such as Nigeria. Something is, I can't hear you right now. No, I can't hear your
No,
next question. Maybe you should. Okay,
can you
yes, I
hear
can
me?
now.
Okay.
Yes,
So
definitely, I can
my
hear you now.
question was this, that since the pandemic, has anything changed in terms
Oh,
of the
definitely.
preparedness of the system to what's happened?
A lot has changed, but a lot more could be done. We have, for example, one of the things that has happened is that we have been able to increase our testing capacity. We've had a lot of training in infection prevention and control generally, and in COVID-19 in particular. We've also conducted quite a bit of research. We've mobilized some of our structures on the ground, though I must say in the areas of community mobilization, I think we could have done much better. We have also been able to get additional care facilities in place for those who might have infectious diseases. So, we've increased our capacity in that area. But I must say that these are still inadequate when you compare it to the population that Nigeria has. As you are aware, we are the largest Black nation in the world, and we are estimated to have a population of 200 million people. So that's no joke. And that's why I say that it's a blessing that despite the predictions for Nigeria, the numbers of cases and deaths from COVID-19 that we've had have been much lower than we thought. And these low numbers are what probably have helped us to be able to respond appropriately to the pandemic and not have our health system completely overwhelmed. But I must say we've gone a little over 1 year now, and fatigue is setting in. There's a lot of fatigue, amongst the health workforce, because the same people, most of the frontline workers, maybe with the exception of in a few areas, they're the same people, doing the work. And there's also this COVID fatigue, which I see it everywhere. People are tired of wearing the masks, tired of social distancing, or rather of physical distancing. And of course, physical leads to social distancing. So people are tired of all these things. I must say, another area where I think we haven't done well is in terms of those basic facilities that are not necessarily core health, such as water and sanitation. Those facilities are still lacking in a lot of areas in a country like Nigeria. And until those are put in place, we will not be able to sustain whatever gains we have been able to make in terms of our response to COVID-19, since it's an infectious disease and water and sanitation is critical in the response. So these are some of the areas in which I would say, we've done well. And of course, there are areas in which there is room for improvement.
Dr. Olunloyo, in the UK, have you noticed any systemic changes as a result of the pandemic?
So yes, definitely, we've had a lot of change. So one of the things that we have is more community working. So when the pandemic hit and we were on the stay-at-home lockdown order, and then obviously we had people who were shielding, who the government said you mustn't go out, you mustn't, shopping, get your groceries online and things like that. We found in our communities across boroughs in the country, people rose up. So for us, we call them our social prescribers. But then they even got people who are volunteering, saying, I want to help. And these people were contacting patients that were shielding, calling them, saying, I can bring your shopping. I can, if the doctor sends a prescription to the chemist, I can pick it up for you and deliver it to your house. We had a lot of that. We had a hub in Greenwich, for instance, and even people that needed food, people who were on benefits, they were able to quickly, revitalize the system in a way that those people could get money if they needed. They could get emergency money, emergency, light and whatever they needed for their bills, while things were being sorted out with the benefits department. So we found that was a fantastic response. We could lean on them because of that. And some of them would just call and say just a friendly call just to say hello. And patients really appreciated that. Apart from that, we also find that across boroughs, GP practices were all working more closely together because we were all trying to figure out how to meet the demand. And not only GP practice, but we are working across sectors. So with all our community services, even with secondary care, because secondary care, the hospitals, they needed us to kind of also be able to hold on to patients and look after the patients we can and be able to quickly refer patients that needed to be referred. And then those who are being discharged from hospital, being able to ensure that we could get their medication and things like that sorted. So we definitely have improved in our joint working, which, previously we were all, in silos. And I can say that after the COVID pandemic, we're still kind of in it. But after this whole year, we can see much more joint working across sectors in the United Kingdom.
There's a point I want to put to both of you this evening, and it's this issue around the substandard nature that some people attribute to medical training and medical facilities that we have in Africa. And this is not just a Nigerian thing. Across all the different nations of Africa, when our leaders are sick, they go out of the country, right? Very few would go to other African countries. They'll go to Europe, US, India, or something like that. To what extent does the training we give our medical professionals prepare them for something like this? Dr. Olufunlayo, let me start with you. You are a senior lecturer as well. To what extent does that training help them for things like this?
Okay. In terms of training, for example, in Nigeria, medical schools are not just run lightly. They are highly regulated, and from all that I know from being an academician for a few years now in Nigeria, the standard of training of a doctor in Nigeria is high. It gives them a basic education to be able to function as a doctor. And this is the reason why, with the exodus of doctors and other health professionals from Nigeria, you see them going to other countries to, top the pack. We are able to hold it anywhere we go because we are given, very good training by people who have been well schooled here in Nigeria. But I would just say that we are now in the 21st century. And things are moving very fast. So we're talking about evolution of a health system. The training we have now, in a few years, may no longer be able to suffice because the world is moving very rapidly with artificial intelligence, virtual media for, carrying out a lot of things. So we also have to adapt. This is where we need to adapt to be able to ensure that our graduates continue to remain relevant. The other thing I'd like to say is that one of the challenges we have in training is this lack of coordination of planning, health manpower planning. We really just train medical students as we have space. We don't really train for the needs of the country or a particular locality, and that's a big problem. And oftentimes, because of the pressures of having few of such institutions for training, we have sometimes the challenge of overcrowding of our facilities. And once you have too many students in a university training for medicine, then there's a problem. Of course, the regulatory bodies take care of this and try to make sure we don't exceed a certain number, but it's always stretching to the max. And so you see students sometimes, looking for the laboratories and the equipment, and these can be solved by newer technologies, bringing virtual technologies for teaching some things. One other area is the fact that healthcare is not cheap in Nigeria, and people often don't come to the hospitals until it's their last resort. So we find out that now training of medical students is being hampered by the cost of healthcare to the patients, because we don't have enough patients to train students anymore on average. So that is also a challenge. But, we do try to make do by sending them out to maybe more rural communities and all that. So these are some of the things that surround medical training in Nigeria. But we definitely give the students a standard training that they can go and excel with anywhere in the world. And that's what they're doing.
Thank you for that, Dr. Olunloyo. I think I'd like to hear your perspective on that question, because you trained in Nigeria, you have been practicing in the United Kingdom for 20 plus years. How do you see that difference?
So I will agree with Dr. Olufunlayo completely. I think the training I received in Nigeria was excellent. And sometimes, you don't recognize those things until you move somewhere else into another country, and then you look back and say, what? I know stuff. And we were really trained properly. We were taken through the basics of taking a history, examining a patient, things that you always need all through your lifetime as a doctor. You always need those skills of listening, what it means to listen to a patient, and because of what they've said, how to now diagnose or think about what possible diagnoses are. So I would say that, I appreciate my training in Nigeria wholly. The only things, as Dr. Olufunlayo pointed out, the facilities, in the sense of the number of things you could see, what you are really exposed to, like here in the United Kingdom, you walk into an A&E, getting an ECG it's just like ABC. Getting a blood test is so simple. Getting something we call the blood gas is the easiest thing, all available right in front of you. That's probably the challenge in Nigeria. You don't have that. And I would say my colleagues and I, that's what we all saw when we came here. There was nothing wrong with it. We had the training, we had the knowledge, we had the skill. What we didn't see as much was all the facilities we could use. And that's what has helped us obviously here. But yes, we were able to, because of our training, we know that I've got loads of colleagues in America, here in the UK as well. And we've all been able to really, achieve things and work excellently because of that.
Before I go back to Dr. Olufunlayo, there's something I want to put to you. And, you talk about the facilities being different and things like that. However, when we're looking at how to innovate the care model, right? What is that next step in innovating the model that we have? And how is that going to be different for you compared to what Dr. Olufunlayo might be looking at, or any other practitioner in sub-Saharan Africa might be looking at?
Well, if you think about it, the way I'll answer your question is, if I thought now I'm going to move back to Nigeria and work and I'm going to practice, what would I want to have available to help me look after patients properly and, actually be able to do my work well? and it would be facilities. And I think that's where the private sector in Nigeria comes in, because I do have colleagues, friends, people who have moved back or have clinics in Nigeria. And one of the things that has helped them is them being able to have the facilities, the equipment they need to use. Obviously, it comes as at a cost. So that then makes it not easily available to every single person in Nigeria, which it should be, because healthcare is a necessity. But that's the thing I would say. How would we innovate is the ability to provide good facilities, to be able to treat our patients, to be able to go in. I think one of the things that frustrates doctors the most is standing there in front of a patient, knowing what to do, but just not having it. Maybe because the patient can't pay for it, and so the hospital cannot give you, or maybe because, there's just no equipment. That's probably the greatest frustration a doctor can have. And I think in Nigeria, that's what we need to do to look at in our hospitals, just simple things. They cost money, but they're the simple things that you need to treat a patient properly.
Dr. Olufunlayo, what would your take be on innovation? You are in that market. You are in that space. What would your take be? I mean, you've talked about artificial intelligence already. Do you really see the culture in that country, one where people would sit down and have a robot, for example, perform an operation on you?
That's interesting. Well, you'll be surprised. Nigerians embrace innovation quite readily, even though sometimes we have cultural barriers, but those can be worked with. Let me actually look at it this way. There are actually some innovations that have been carried out in some years back in Nigeria in the health and other sectors, which were not needed in more developed climes because maybe they had all the infrastructure and the technology, but are now being used in those countries as a result of pandemics like COVID. So there's this thing called reverse innovation. So that is taking place. And that's one thing we should look at. We should look at those appropriate technologies. I mean, that's from primary healthcare. Those appropriate technologies that we are using, that we can expand upon and help us to leapfrog into this new dimension of healthcare post-COVID. So there's that. And then, of course, the world is becoming a global village, or it is a global village now. And with COVID-19, we have realized that even if the high-income countries are free of COVID, if the low and middle-income countries still have COVID moving around, no one is safe. So there's a mobilization of resources and technologies to ensure that they bridge that technology gap so that they can bridge the health gap as well, and everybody can, have a better status of health. So I think what we need to do is to leverage on such opportunities, not as opportunistic people, because we also have something to give. It's a win-win for everybody, really. But it's an opportunity for us to leverage on those technologies that are being mobilized to ensure that we all experience better healthcare at this time. So that's the way I would look at innovation. In the past 5-10 years, maybe we had people donating equipment. Maybe, they've updated their dental chairs, for example, in a particular hospital or facility, then they ship them down here. That's fine, because, we have need for those things. And like Dr. Olunloyo said, they're quite expensive here. So we appreciate such things. But right now, I think it's going beyond that. They realize that we just have to bridge that divide, and we all have to be at a certain level. And we are also taking technologies from our environment that have worked in resource-poor environments, and we're also making them global because they are relevant all across the world. So that would be my take on that.
All right. Now, before we leave the conversation on innovation, I want you to speak specifically, Dr. Olufunlayo, to the impact of culture on this new technology that is coming. Even if we had all the investment coming in, the AFDB released a report, and one of the things they said there was, look, increased wealth doesn't necessarily mean improved health, particularly when you're looking at some of the poorer nations of the world. So the fact that we've got this newer facilities in there, some people may look at that and say, well, it doesn't really mean that the culture lends itself to the training. What is your take on that?
Okay. I think one important step that must not be overlooked is the involvement of the community. Communities must own their health. They must own their health systems. And so it's important for stakeholders when they're planning on innovation to involve those that will use it, the end users. This is something that is practiced in, other climes such as the United Kingdom. The patient, the consumer is very important. He is king, and his input is always sought before technologies are changed. But here we haven't really imbibed that lesson, though we have vanguards that preach it. And I think that is an important aspect. So we must take them along. Yes, we can sell the ideas to, people that this is what we want to do, but they must be carried along. Otherwise, they may reject, the use of those technologies, those facilities, and so on. So I think when we talk about culture, that is important. And when we get their feedback and their input, then we'll be able to design or package those innovations in a culturally or socially acceptable manner, such that we wouldn't put them down and then have nobody use them, as we have seen in decades past in our environment. So this is an area that we still need to get right 100%. And that what I mean is the ownership of health and healthcare provision by the localities or the locals.
Dr. Olunloyo, do you want to respond to that?
I agree completely with Dr. Olufunlayo, and I think it goes across, all cultures. Even here in the United Kingdom, I will use an example about the COVID vaccine. So yes, we got a vaccine, we were rolling it out, but people were hesitant and they did not want to come out and have this vaccine. And what we did was we took the instruction, the webinars into communities. We went into different communities. We went into churches, mosques. We got people who are community champions who to come and speak to their own. We got people who, for instance, we had a group of the Nepalese who are organized into their own community. They're basically their own community. We got people to go and speak to them and explain and speak to them in language they understood about, the vaccine. We got them to ask their questions and their concerns, and we were able to then feed back the answers. And then when they were then happy to take the vaccine. So definitely health promotion and is something that must be owned by every individual, must be preached by every community. I mean, I always say this, that the saying prevention is better than cure is as true as it was 100 years ago, and it's true now. We need to keep going out, talking about it, talking about the diseases, talking about symptoms, signs, talking about what people can do to prevent these things. And if we're going to bring new technology, talk about it, explain how it works. Information is key. The minute people understand, they will not be afraid. Then they'll be able to take it on board.
Thank you for that. There's a point I also want to bring to the table here, and that is when we look at the impact of population. We've talked about culture, and we're going to end on opportunities in a minute. But when we look at the impact of population in Africa, one of the things that people have talked about is that the growth rate is something that we expect to expand in future? And to what degree do you think that is going to bring more pressure on the system in Africa? And I use Africa in a generic sense, right? Because it's not just the Nigeria context. I'm talking about all across Africa, because the same issues we have in Kenya, we're having in Nigeria, we're having in South Africa, Uganda. It's all over. What do you see the future of this challenge that's brought about by an increase in population? Dr. Olufunlayo, do you want to pick that first?
Okay. Well, is this change in the demographics of various countries. It's taking an interesting turn in sub-Saharan Africa, most of those countries, because population control is not as much an issue as it is in the developed world. And this is because there are a lot of cultural barriers towards limiting population. So, and we haven't focused on it, and we really should. Quite a number of experts have, called for that. However, our population is expanding rapidly. And for example, in a country like Nigeria is set to likely have the world's 5th largest population in a matter of about 20, 30 years. So it is definitely going to put a lot of pressure on the infrastructure, especially in a continent and a country that does not plan very far ahead. It is said that in some other countries and climes, they build hospitals, build schools, build residential areas in anticipation of the next generation. We are trying to catch up. Okay, we are playing the game of catch up. Many people are homeless. Many people do not have access to healthcare. Universal health coverage is still, a mirage in Nigeria. So if our population continues to grow rapidly, it will definitely put a lot of pressure on the healthcare and the resources of the nation. But it's also an opportunity because it means we have more human resource to, groom for the health system, more human resource to develop the economy of the nation. So it depends on how you look at it, and it really depends on how these resources are harnessed. But it's going to be a challenge of some sort because a lot of the countries that they have their health systems working very well do not have their populations growing as rapidly as we do. And when you do have a population that grows this rapidly, you must do something very smart to be able to meet up with the needs of that growing population. And of course, with the growing population, there will also be trends in the infections, the different diseases, what we call the epidemiologic transition. So we need to look more closely as a country and as a continent at these to be able to plan our health manpower, to be able to strengthen our health system in the right direction, and to be able to take the kinds of population-based decisions at the leadership that would take us to the next few generations if we really want to do well as a nation.
Thank you for that. Dr. Olunloyo, you are clinical director for a network of practices here in the UK. How do you address the population issue?
So, that's a big thing. We always work very closely with public health, and we always get data based on our population and what, the ethnicity of our patients and things like that. And using that, so what you find is that, so for instance, I work in the borough of Greenwich. Even across Greenwich, there are different types of needs, and the patient population changes a bit. So you can have some more affluent areas of Greenwich. Their needs are different from the less affluent areas of Greenwich. But what we have is we have data. We have data, and we use that data in treating our patients. And you find that we find us we have registers. So if a patient, for instance, is diabetic, it goes on a diabetic register. Why? Because then the patient can be called for 6 monthly checks, or, have regular blood tests and things like that. We also have different health promotion events that goes out telling people, do you know your numbers, blood pressure, weight. We do blood sugar checks, spot checks out there to also take into consideration these people. And obviously we have loads of data on different things. So that's how we work. And what we do is, as you said, at my network, we're in the same area. So basically we have generally the same sort of patients, demographics, ethnicity, health issues, even deprivation. And what we do then is we're working together as a group to bring together our resources so that we can provide better services to our patients, and also to work better with other community services as well as with the hospital. Because then instead of one person just dealing with one practice, you can be dealing with 6 practices at a group. We can then, create new ideas of how to reach our patients better, how to treat them better, and generally bring the health care, to a much better level.
All right. One area that I want to put to both of you is this area where we look at the opportunities, despite the challenges in sub-Saharan Africa. What are the opportunities that we have there? And Dr. Olufunlayo, like I said earlier, you are on ground in that place. You are training others to become doctors. If someone was saying, what is the attraction for choosing to be in sub-Saharan Africa in the health sector, what would you be saying to that sort of person?
Okay, so many reasons. First of all, the fact that a country like Nigeria has 200 million people. I mean, that in itself could be looked on as an opportunity. And we have so many brilliant minds, people with the capability to do well, who've gone through medical, nursing, pharmacy, physiotherapy, dental school, different, allied health care professions. Some of them have stayed back in Nigeria. Quite a number of them have moved to other climes and are doing excellently well. But the thing is, we still need to set up a health system that works in our own part of the world, a system that works well, that, is responsive, a system that provides services of a certain standard to people, a system that prevents people from, having to spend monies that they don't have on healthcare. So we want to improve the system, and that's the reason why we are here. We just can't all, leave. But talking about the opportunities, really, I think we have a large pool of, already trained health workforce that, if the environment is conducive, would stay and help to build this health system that we want to become very resilient and to be able to take care of the large numbers of people living on the continent. So I think that's one opportunity. Another opportunity I had mentioned earlier is the issue of, COVID-19 and the partnerships, the public-private partnerships, the international alliances and partnerships, to ensure that everybody has an opportunity of, gaining access to what is needed to be able to combat the pandemic. So this is a huge opportunity for a health system like that in Nigeria to leverage on and access technologies, funding, equipment, training that we didn't have access to before. So this is really a time, of opportunity for us as a country in the health system to really be able to leverage and take a leap forward at this time of the pandemic. The pandemic has acted as something like a leveler. So it's our time to really leapfrog, jump on all the opportunities and maintain. The issue here is sustainability. If we can sustain whatever gains we make now, then we would have leapfrogged. But the issue is that sustainability. Can we do that?
Thank you. Dr. Olunloyo, what sort of government policies are you aware of that will help some of the developing nations and developing economies in their quest to be better?
So I think I'll answer that question slightly different. I think that I agree with what Dr. Olufunlayo said, and I think one of the most important things is for governments, and using Nigeria as an example, to really listen to their doctors, to listen to their healthcare professionals, to work with them so that they can make a system that works. I think that one of the biggest things we have to understand is that health is not it's a commodity, but it's something that should be free. Everyone should have available. It isn't a privilege. It is something that you need. And that's one thing that I think is missing in a lot of African countries, and using Nigeria. It's just, the fact that we need to provide, the best thing would be to provide a system that is free at the point of need. A patient walks into your emergency and you can immediately treat them without first waiting for them to pay for the card, pay for the blood test, but that you can treat them. But one of the things is, as Dr. Olufunlayo said, there's so many brilliant minds. There are people that have been trained in Nigeria. They've come abroad to do residency and they've gone back to Nigeria and they are working there. One of the things is for the government to actually listen to their public health officials, listen to the doctors on the ground, and find a system that works. We can look at the Western world and say, oh, America is like this, England is like this, different countries are like this, but we need a system that works for Nigeria. And I just want to quickly say something. Like when I was training, we did a community posting during our training, and we had to go to a little town called Igora, and that was sort of our, the village, and we went out there as students with our teachers, and we went out talking about the benefits of water, good hygiene, vaccination. We were doing that in that community. Can you imagine if we took that message and spread it to all the places in Nigeria and to all the cities? But one thing that people they distrust a system that when they need help, they walk into a hospital and you can't help them. And they're dying, or they see their relative dying, and you say, unless you bring out, money to pay for this, we're not going to be able to do that, treat you. And I think that that's one thing. Governments need to listen all over the world, to be fair. Governments need to listen to their healthcare professionals. They are the people doing the work. They're the people seeing the patients. They're the ones that can say, this will work if you do it this way. Otherwise, everything is theory.
Dr. Olufunlayo, if there were two things that you would say you want to see change in the health sector, what would those two things be?
Okay, I would say leadership and governance, which is one of the building blocks, and then increased funding to come closer to what the African Declaration, Abuja Declaration says, 15%, somewhere closer to that. So leadership and funding.
Dr. Olunloyo, we have about 2 minutes to go. What would you want to see change when it comes to the health sector? If there were two things that you could say, these two things, press a button, they happen, what would they be?
So two separate things from what Dr. Olufunlayo said would be a healthcare system that is free at the point of need. I think you can't get past that. That's one. and just greater care for our community, more community services, more care being shown, the care being taken out of hospitals into communities. Those are two things I would say.
I'm going to probe a point, and I'm going to ask both of you to respond to this, if you don't mind. And the question is this: we talk about funding, healthcare being free at the point of access, but surely somebody somewhere is paying for the drug. Somebody somewhere must be paying the salaries of the doctors, the nurses, all the healthcare professionals. How do you balance that?
Oh, well, that's why we have different mechanisms for paying for healthcare. And I mean, one of the most popular is health insurance, which have various models. So the money does come from somewhere, but the issue is at the point of care, the out-of-pocket payment should be minimal to allow the patient or the client to be able to access it without that barrier. When someone is ill and he has to start going around looking for a loan to pay for healthcare, then I mean it's just really so bad. Or he's in an emergency, like Dr. Olunloyo said, and he cannot access care immediately because he needs to look for a certain amount to deposit. It's really an issue. So we're not saying it will not be paid for, but at the point of care, that it should be free or a very small out-of-pocket fee for them to be able to access it if we want people to utilize healthcare. And this is one of the cardinal points of universal health coverage, which we really, really need to get right in our own health system.
Dr. Olunloyo, do you want to respond to that before we go this evening?
So I agree.
Actually,
completely.
hold on. Some people say that while we have the NHS and people can go to the NHS, it's free, that model is actually not a sustainable model.
Yeah, I mean, the truth is that the government does put a certain amount to help. Okay, so that's there. And we do pay taxes and we have national insurance contributions. Okay, but we have a system in this country about looking after people who cannot, and that kind of works. I agree, the NHS is not everything. The NHS cannot be the be all and the end all. I work in it. I understand the limitations, but there's one thing that you can't take away. The fact that you are ill, you walk into an A&E and you can be treated in this country. If you think about it, it's not just Nigeria. If you go into America and you don't have insurance, they might not treat you either in an emergency, unless it's a real, emergency. Sometimes they will, but then they'll still charge you. But I'm talking about a system that says, I don't care if you don't have money, you are sick, I need to treat you. That, it goes against everything within a doctor to be able to say, sorry, I can't do anything because you haven't paid your money for your registration card. That's not why we trained. That's not why we're doctors. We're here to help. So yes, the government needs to put a certain amount of money into health. And then we need to tax people appropriately. I'm sorry, it sounds really like, oh, you want to take, yes, we need to do that. And then we need, contributions. We need that universal health coverage. Nobody's saying you won't have to top up and go to private if you want to. People do that even in the United Kingdom. They have private insurance. But, if you really want to reach a community, you want a country to survive, there are people to survive. You need that sort of healthcare system.
Fantastic. Thank you to both of you. This has just been enlightening for me and amazing. Dr. Olufunlayo, thank you for joining us from Nigeria. Dr. Olunloyo, also thank you so much for sharing from your experience. And to our viewers in the virtual studio, I hope you've picked up one or two things listening to these two great minds. Thank you again for being there. And to our viewers across all the platforms, thank you once again for being there. And we'll see you again next week. Same time, 6 p.m. UK time, and all other countries will take their time from there. Thank you and goodbye.